Welcome to Hip Examination Part 1. In this presentation, we'll discuss the subjective examination for a patient who has hip pain. I also want to acknowledge Dr. Greg Ford, who developed much of this presentation. For this particular presentation, we have three primary objectives. The first is to describe the global impact of hip pathology and the role of the physical therapist in management and prevention. Discuss the different pain and function patient self-report questionnaires that may be used with individuals with hip pain, and evaluate data from the subjective examination to assist in making clinical judgments to establish a diagnosis or differential diagnosis for individuals with hip pathology. For this particular lecture, there was one article that I wanted you to be able to read beforehand. And the title of its First Line Interventions for Hip Pain is It Surgery, Drugs, or Us by Rob Weiner and Julie Whitman, and was published in 2007. And we'll talk about what's kind of going on today with respect to the management of hip pain. But back then when they wrote this paper, they talked about hip pain not being as prevalent in PT clinics as some other diagnoses, like maybe low back pain or neck pain or even maybe knee pain. And if you look at the literature, about 14% of individuals at any one time are going to complain about hip pain. However, if we start to look at more degenerative changes at the hip, like osteoarthritis, up to half of the population over age 50 are going to have hip pain associated with function, and that number is going to go up as age increases as well. And so hip pain is pretty prevalent. And if we look at some of the data out there with respect to what are the management strategies, the vast majority is going to be surgery and medications. Very few studies have actually looked at conservative non-pharmacological approaches. And if we look at those studies that have examined that, most of it deals with some form of exercise, and really manual therapy really hasn't been included in those trials. And if we look at some of the practices of physicians, we see very few physicians recommending exercise. Those that do usually just recommend it in a broad sense, telling patients to exercise when you can. And that's a concern because that really is opposed to the evidence that we know that sound therapeutic exercise and manual therapy delivered by a physical therapist is really the best way to approach that. We even see physicians prescribing bed rest for patients, and we know that that is probably not the best thing either, because with bed rest we begin to see patients getting weaker and having more difficulty with function. So those are concerns. And so while the majority of our patients in PT clinics may not necessarily have primary complaints of hip pain, we do see an awful lot of patients with lumbar disorders as well as knee pain. And it's not uncommon for these folks who have lumbar and knee pain to have involvement at the hip. In fact, they argue that we should be examining the hip more and treating the hip more in these individuals. And I would agree with that, especially in older individuals who have knee OA. We know there's going to be hip OA associated with that. And those impairments up at the hip, especially for patients who are a little bit older with some lumbar spine issues, can really help with their course of care. And so we'll talk about, as we go through the hip and then we integrate the lumbar spine a bit later, how we want to manage those impairments at the hip, whether they're primary or secondary for the patient's case. And so the bottom line here, they recommend that we really have to get out and do a better job of getting these patients into the clinic that we can help. Because like I said, their main options are surgery or medications. Surgery, certainly for some older patients who go on to arthroplasty, that's necessary, especially in cases of severe osteoarthritis. But the medications that they take, the primary medication is going to likely be non-steroidal anti-inflammatory drugs, which are very concerning and very dangerous for some of the older individuals who take those. And so we really need to get these patients in the clinic and really treat these folks and really help them with their outcome. And so the first is to make sure we educate and market referral sources. We want to talk to our patients who are out there. We want to make sure we get these folks in the clinic, and we want to educate physicians out there that, what we can do for these folks and what the options are to what they can do. And then finally, when we do see these patients, we want to make sure that we can use the best current evidence that really relates to sound manual therapy principles and therapeutic exercise that really help us inform the care of the patient. So at the end of the day, I think the editorial, the article was a good one for you to do, because it really helps you understand some of the global impact of hip pain, how it's currently being managed, and how we can play into that, and hopefully really get patients better quicker with interventions that are much safer than the alternatives. We've discussed this slide before, and it deals with the top causes of disability worldwide. Along the top, those are the top 10. That's the top 10 list right there. And then along the left side, in the vertical column, are going to be the age groups that are affected. And if we look at the number one cause of disability, we've talked about this before, between individuals 25 and 64, it's back and neck pain. If you move over to the left a little bit and you start looking at category 5, 6, and 7, you begin to see, especially with older individuals, other musculoskeletal disorders as well as osteoarthritis begin to creep in. Those osteoarthritis complaints primarily deal with the knee and the hip. And as we mentioned before, with regard to the back, it's not uncommon for especially older individuals who have primary complaints of lumbar pain to have hip pathology that's also influencing their current levels of disability. And so I think that it's important to know that these cases are out there. We need to get these folks in the clinic, and we need to manage them effectively. And so not only does low back pain, musculoskeletal disorders, and osteoarthritis cause a great deal of disability, but it's also extremely costly. This paper was published this month, March of 2020, in JAMA, and it looks at the costs of different types of medical conditions. And on the right-hand side, you can see that musculoskeletal disorders is the most costly by far. It's hard to put $380 billion, how much that really means. That's essentially about $720,000 being spent every minute in this country, every day, 365 days a year. And so that is a great deal of money spent on the care of these individuals. What makes that up? The majority of it is back and neck pain. But again, osteoarthritis of the hip and the knee play into that as well, primarily because so many of those folks go on to have surgery, and surgeries are costly. And so you'd say, well, $380 billion, that's okay, because all of these individuals are getting better. And that's not the case. If you refer back to that last slide, we talked about the color scheme on that graph. And anything that is not green means that it's either staying the same or getting worse. And when it comes to all of the disorders that we're describing, the musculoskeletal disorders, osteoarthritis, as well as back and neck pain, we haven't been able to get a handle on that. And these individuals are actually getting worse over time as a population, which is a concern. first measure we'll describe is the WOMAC, or the Western Ontario and McMaster University's Osteoarthritis Index. This is a very, very common scale that you're going to see used with older individuals who have hip osteoarthritis. It's also used for the knee as well, but it's used commonly in clinical practice and research. And the patient completes this survey. It looks at 3 different domains in the areas of pain, stiffness, and physical function. And within each of those domains are different variables that are assessed on a scale of 0 to 4, where the patient has essentially no difficulty up to extreme difficulty. There's 24 items, each one's worth 4 points. So it's a total of 96 points, and the higher the patient scores, the more functional limitation they have. And so when we look at giving a patient this instrument on day 1, and then we reassess them, say, in 2 or 4 weeks, we're going to want to know, did the patient have an improvement? Is the patient improved? And so we call that, right, the minimal clinically important improvement. And it really looks at what's the minimum score necessary for the patient to report a substantial improvement or change in their symptoms for the better. Overall, for the instrument, it's about 9 points. If we look at, though, scores at baseline, like if we look at individuals who have a low baseline score, which means they have a higher functional score to begin with, so they come in with higher levels of function, anything less than 35 points, we want to see changes of about 5 points to determine that the patient is improved. If we're dealing with intermediate scores, anywhere between 35 and 51, we're looking for change scores of about 11 or 12. To know the patient improved. And if we're dealing with higher scores, these are individuals who have high levels of disability, very limited. If the scores are over 51.5, we're looking for changes of about 20 before we know that the patient has had a significant improvement. And so again, this is an important scale. It's used clinically as well with research that you should be familiar with. And so here's what the WOMAC looks like. As I mentioned, there are 3 domains to this particular instrument that relate to pain, stiffness, and physical function. Again, it's an instrument that you give your patients, have them complete it, and you can come up with that score that'll give you some understanding of how they're functioning at baseline. The next outcome measure we'll describe is the Harris Hip Score. And this particular instrument is typically used with a wide range of patients. So you'll see this in the literature with younger, more active or athletic individuals, as well as individuals who've undergone total hip arthroplasty. So there's a wide range of uses for this particular instrument. And this particular scale looks at 4 different domains which relate to pain, gait, mobility, and deformity. And it's scored by the physical therapist. And we can look at the baseline scores and we can get a general understanding of where that patient's functional level is at. So it's scored on a scale, again, of 0 to 100, and the higher the individual scores on this particular scale, the more ability or less disability they have. Now that's different than the WOMAC, where the WOMAC was the higher the patient scores, the less ability they have. This is just the opposite. So the higher score in this case means the person's actually doing better. And so you can see those score ranges there. With respect to a minimal clinically important difference, which is again a score that you would need to see for a patient to report a significant improvement in their symptoms. In this particular study, we're looking at femoral acetabular impingement. So these are younger individuals who've undergone surgery. We can see that those scores at 3, 6, and 12 months are anywhere between 9 and 20 points. The farther we move out as the patient improves, those are the scores that we're going to want to see. And so with respect to the MCID for this particular score, I think that if you're using it, I think you should at least see a score anywhere between, a change score of anywhere between 10 and 15 points. I think that's an important score to look at for these individual changes to determine if there's improvement or not. If the patient is scoring a little bit lower, expect that score to be a little bit larger. If the patient scores higher, expect that score to be a little bit less. But once again, it's an important measure that you'll see most commonly in research, but also in clinical practice. And so here's the Harris Hip Score. You also have this on the Blackboard site as well. This would be the paper and pencil version of it. And you can see those 4 domains: pain, function with respect to gait, function with respect to activities, and then deformity and range of motion. Each of these has a score associated with it. Again, it tallies out to be 100 points. And I would recommend that when you use this clinically, I think there are several online calculators that work really, really well in tabulating the score. The first areas relating to pain and function, and even the deformity component, are not that hard to score. But when it gets to the range of motion, you're trying to determine how much total range of motion does the patient have for flexion, abduction, external rotation, and adduction. And so that can get a little bit tricky with the scoring, and that's why if you look at those measures, you can use these online calculators, and there's an example of one down there from orthotoolkit.com, and they do all the work for you. It makes your life very, very easy. But again, it's a good measure. It looks at some measures with relating to the history as well as the physical exam that are important in looking at how the patient's functioning at baseline and ultimately how they're going to improve over time. The last measure we'll look at is the lower extremity functional scale, and this particular scale has 20 different activities. Each of the activities are rated on a scale of 0 to 4, and the patient can complete this one on their own. You have a total score of 80 points. The higher the score, the better the patient is functioning. And when we look at sensitivity to change, we want a change of about 9 or 10 points from baseline, and that really tells us that the patient, if they exceed that threshold, that tells us that the patient has had a tangible, substantial improvement in their symptoms. And here's a look at the lower extremity functional scale. As I mentioned again, there are 20 different activities, and if you study the different activities, you can see they range from very, very low level activities to things like rolling over in bed to very high level activities like hopping. And so this is a scale that you'll see used commonly with a wide variety of different patients' ages and ability levels. And again, a higher score indicates a higher level of ability. It's an outcome measure that was designed by physical therapists, for physical therapists, and something that is quite helpful clinically to use as well. Just a couple of other considerations when you're thinking about assessing outcome with your patients. The 3 scales that we mentioned previously, the Womack, the Harris Hip Scale, and the lower extremity functional scale, you would never use all 3 of those with a patient in routine clinical practice. I would recommend picking one and using that with your patient. So pick one of those 3 measures that you prefer. And then there's a couple of other considerations that you can combine with that one particular outcome measure that you're going to choose to use. First is pain. Numeric pain rating scale is something that I would recommend that you use with all of your patients. And as we've talked about previously in the course, this is a pain rating that we're going to use on a 0 to 10 scale. We're going to ask the patient to rate their current level of pain and then their best and their worst levels of pain over the last 24 hours on that scale of 0 to 10. We're going to average that score, and then we're going to reassess the patient in a week, 2 weeks, a month, whatever the time frame is, and we're going to look for that change of at least 2 points. Again, like we talked about before with these minimal clinically important improvement scores, that 2 points suggests that the patient has likely had some substantial improvement in their symptoms if you see that. So that's the first consideration. The second consideration is, let's say you forget to do any of these measures and you don't do any of these measures at baseline and you still want to assess your patient, let's say 3 to 4 weeks into therapy. You can still use the global rating of change scale. We've talked about that before with respect to the spine. And this is a very, very helpful measure because you can assess the patient down the road without having a baseline measure. And remember, you can't give this to the patient on day one, because if you look at those descriptors that are on the screen down there, there's 15 of them. And we get a nice indication if the patient's about the same, maybe they're worse, but hopefully they're better. And if you're trying to determine, well, what is an important improvement for my patient population, in general, if you're looking at a 4 or a 5 or greater, meaning the patient tells you they're moderately better or quite a bit better or anything more than that, those are really, really indicators that suggest that you're having a positive outcome on this particular patient. You could potentially see scores that are a little bit lower, like maybe the patient's very, very chronic, or perhaps their hip osteoarthritis is a bit more severe, and you may see a score of 3, which means they're somewhat better. And that may suffice in some cases, but bottom line here is usually scores of 4 or 5 or greater suggest substantial improvement with respect to the patient case. Now that we've described some of the outcome measures that are helpful in evaluating patients with hip pathology, let's move into our subjective examination. And the next several slides in this presentation will deal with the questions we're going to ask patients who primarily have hip pathology. And they're going to relate to the patient profile, which are factors like age, recreational activities, job activities, sport activities, etc. Where's the patient currently at with those activities, and how are they limited? We're also going to look at the history of the injury, and we're also going to want to know about where are the symptoms currently located, and then what's the behavior of those symptoms, right? All of that information is really going to help us with respect to leading us into a very, very effective physical examination. And then finally, we'll talk about special questions. And these special questions are important because at the hip, you certainly could have non-musculoskeletal pathology. And if that's there, we want to make sure those patients are referred out as quickly as possible to the appropriate provider for the appropriate medical workup. With respect to patient history, we certainly want to pay particular attention to age, as age correlates well with different pathologies, especially at the hip. For example, laid calf perch disease and slip capital femoral epiphysis, we typically see these in children. Laid calf perch disease is a form of avascular necrosis or osteonecrosis that we see in children. And slip capital femoral epiphysis is where the femoral head slides or slips relative to the femoral neck at the growth plate in children. Both of these, like I said, we see these typically in adolescence. Labral pathology is another pathology that we typically see in younger individuals, especially those involved in athletics who particularly stress the hip. We could see them in older individuals, see labral pathology in older individuals as well, as in more of a degenerative fashion that would go along with hip osteoarthritis, but we would certainly see this in younger athletic individuals. Fractures can happen at any age. I think the amount of trauma, though, is going to vary with respect to fractures in younger individuals, meaning that you'll have to have significant trauma for fractures in younger individuals compared to older individuals who may have metabolic bone disease, osteoporosis. We may not need to see as much trauma in those individuals to see a fracture. And then, of course, osteoarthritis, wear and tear of the joint. We're going to see that in a significant population over 50 years of age, as age is going to be a risk factor for that wear and tear over time. With respect to our history, we're also going to want to learn more about the individual's occupation and the amount of stress that that particular job places on the hip. We'll want to know how long the individual has had that particular job, and we want to know what type of restrictions or limitations the person currently has with their work. Those are important to know because we may use those as our goals in physical therapy to try and get the patient back beyond those current limitations or restrictions. It's also important to know what the person's expectations are with respect to returning back to that type of activity in their job. In addition to occupation, we'll want to know about hobbies or recreational and sporting activities the individual is involved in. These could be significant factors that could lead to hip pain. If you think about a runner or somebody who is involved in athletics that stresses the hip, these could certainly be factors that could be causing some of their symptoms, and we may need to back those individuals off from those particular activities with respect to relative rest. We also want to know how an individual is limited or restricted in their particular activities at this point. Again, we want to know what the individual's goal is going to be. Do they expect to return back to that high level of athletic activity, or do they have expectations that they're going to cut back on that activity at a certain point in time? Those, again, are important to know when we establish our treatment goals as well as establish prognosis. As we mentioned with respect to occupation and recreational activities, we'll want to know what type of force those particular activities are placing on the hip. And is there a need for us to limit those activities to allow the individual to potentially heal? We'll want to know, is there a mechanism of injury as well that brought their hip pain on? Was their hip pain insidious in onset, meaning it came on slowly and progressively over time? Or was there a specific incident that brought that on? Is the individual involved in an activity where we see repetitive loading of the hip? That would be more of an insidious onset. Or was there a trauma, a singular event that brought the individual's symptoms on? Those are all important to know, especially from a treatment planning perspective. For example, if repetitive loading through a particular activity, say running, has brought the patient's hip symptoms on, we may need to back that off a little bit and give the individual some other activities in the meantime that are a little less aggressive with respect to loading of the hip, and that's going to be helpful with respect to our treatment planning. As we move through our patient history, we're certainly going to ask the patient where their symptoms are located. And with regard to the hip, we could see symptoms in a variety of different areas. The hip can refer certainly into the anterior and posterior aspects of the hip. It can refer laterally. It can also refer into the thigh and into the knee. It can refer more proximally up in the lumbar spine region as well. With respect to symptom location and patient complaints who have hip osteoarthritis, it's interesting to note that the most common area of symptoms is usually lateral at the greater trochanteric region, followed by the anterior thigh, then followed by the knee, and then lastly into the groin region. And so these areas of symptoms are going to be important as we begin to hypothesize about what the potential cause or pathology might be with respect to the hip. I mentioned that in patients who have hip osteoarthritis, it's not uncommon for them to have pain through the lateral aspect of the hip or into the anterior thigh or even into the knee. It's also not uncommon for individuals who have hip pathology to also have pathology in the lumbar spine. And so it's important to know that if we see a patient who potentially has symptoms into the anterior thigh or into the knee, that we have to consider, is there some lumbar involvement as well? And it's important to review and keep a close eye on these lumbar dermatomes. And so take a moment and make sure that you review your lumbar dermatomes. We'll talk more about this as we progress into the lumbar region, but I know that these were discussed during the lower quarter screen, and so it's important again to review these, because if we do see symptoms into the anterior thigh or potentially into the knee, right, we have to consider lumbar involvement. This slide presents symptom maps for lumbar dermatomes, and you'll note that L2 can refer into the anterior thigh, L1 can refer into the groin, and L3 can refer into the knee. So it's important, again, when we're dealing with individuals who present with symptoms into the anterior hip and thigh and the knee, to consider lumbar in our differential. One important part of the history is to take time to closely evaluate the patient's body chart. And we want to begin by looking at the quality of the patient's pain and how do they describe that. In the body chart on this slide, this is one that a patient completed on their own. You can see they used arrows to describe their symptoms in the posterior and anterior aspect of the hip. In this particular intake, those arrows meant sharpshooting pain. It's not uncommon also for patients to tell us that they have a dull ache in their hip, and certainly we could see other symptoms like numbness and tingling as well. However, when we see numbness and tingling compared to sharp shooting or a dull ache, we may begin to think about some neurologic involvement. And so sometimes the way a patient describes their symptoms and the location of the symptoms, it certainly can help clue you in. Once again, when you think about the anterior and posterior aspect of the hip in this particular patient, you could say that this could be primary hip pathology, but it also could be referred from the lumbar spine as well. So with this particular type of body diagram, we're going to have to gather more information to determine what particular area we're going to examine most closely and what areas are we going to screen. The quantity of the pain is going to be important as well, and we can use a 0 to 10 measure for this. So a good way to do that is to determine what's the patient's current level of pain on a scale of 0 to 10, and then ask them over the course of the last 24 hours what's their best and worst pain been on that same scale of 0 to 10. Take those three numbers and average it, then you can use it as an outcome measure. You can reassess the patient in a week or two and determine how that measure changes. And we've talked about this before, that we'd hopefully want to see changes of at least 2 or more points to begin to know the patient is really experiencing changes in pain that are outside of what we'd expect with measurement error. It's also important to know what are the factors that make the pain better and worse, aggravating, easing factors. We'll talk more about that in a moment. That can certainly help point us in a direction of a lumbar spine or more of a hip type problem. 24-hour behavior is going to be important. We want to know when are the patient's symptoms best and worst over a 24-hour period. For example, we may hear a story of a patient who tells us that they sometimes have a difficult time sleeping. They wake up first thing in the morning and their hip is really painful. And it's not until they're up and around for about 30-45 minutes that their hip starts to feel better, and actually feels better through the course of the day with movement. That's a very different story than a patient who tells us they wake up and they feel fine, but it's not until they're at their job 8, 9, 10 hours, and as the day wears on, their hip really begins to bother them. And so those are two very, very different scenarios that we would want to address likely differently. And then finally, we want to make sure that we address the patient's sleeping. Sleep hygiene is a big topic right now in rehabilitation medicine, and we can help patients a great deal get the type of rest that they need to heal. So we may have to find out what positions they're sleeping in and make some recommendations to help the patient sleep better. With respect to medical tests, it is important to know if the patient has had any imaging done along the lines of plain film radiography or x-rays, CT scans, MRIs, or bone scans. Those are all important to know if the patient has those and what are the results of them. On the previous slide, I mentioned that we can look at aggravating and easing factors, and it can help clue us into if it's more lumbar or hip pathology. And so this particular slide lists some of the positions and activities that, if we're dealing with a lumbar issue, could potentially make the patient worse. So for example, sitting or bending forward or coughing and sneezing. Those are activities that we would think might be related more to the spine than to the hip. Certainly walking can influence the lumbar spine in some particular patients. That can also be a hip symptom as well. This slide looks at activities and positions that could potentially be problematic for a patient who has a primary hip problem. One activity that you'll want to ask your patients is about crossing their legs. That adduction and flexion moment at the hip that we see with crossing the legs can sometimes cause a primary hip problem to get worse. And even if we have a patient who tells us that they have pain with sitting, sometimes trying to determine if they sit in a low or a higher chair, does that seem to make the symptoms better or worse? So for example, as the hip flexes more with sitting in a lower chair, that's going to aggravate the patient's symptoms compared to sitting in a higher chair where the hip is not in that position of extreme flexion. We may not see a problem at all. And so that might be a way to kind of sort out if that sitting is related to the lumbar spine or the hip. If we raise that hip, if we raise the individual up in the chair, does that change their symptoms? On the last slide, I mentioned that it's important to investigate the special tests that your patients have had done. One special test that's important, especially for patients who are at risk for metabolic bone disease and decreased bone density, would be a DEXA scan, or a dual X-ray absorptiometry test. And a DEXA scan is kind of neat because it sends two different types of X-rays through the hip. That's where that dual comes from. And it determines how much of that X-ray beam actually passes through the hip. In a healthy hip with normal bone density, most of that X-ray beam would be absorbed. However, if you're dealing with a hip with decreased bone density that's a bit less dense, that X-ray beam is going to be able to be pass right through and get picked up on the other side by the detector. And so we can determine how much bone density there is by looking at where does that individual fit with respect to the normal population. And so on the left, you can see, left top, you can see how that X-ray looks, and then you can see some of the computer graphics associated with it. And then on the right, you can see that anywhere between 1 and 2.5 standard deviations, which we call a T-score, the individual is considered to have osteopenia, and anything more than 2.5 standard deviations below normal, the individual is considered to have osteoporosis. And so, once again, we're looking to determine how much bone density does the individual have compared to a normal population. And individuals who have osteoporosis and even high-grade osteopenia are at risk for a fracture. And so what are some of the risk factors that we see as contributing to osteoporosis? Women who are over 65 years of age and who weigh less than 140 pounds at menopause. And part of the concern with menopause is that after menopause we see less of the female hormones, estrogen and progesterone, and those play a key role with bone mineral density. Corticosteroid usage as well is another factor that could potentially influence bone density. So if we see women who are older, whose body habitus is a little less or a little more slight, these are individuals who are going to be at higher risk for osteoporosis. And the DEXA scan is important again because it gives us some understanding of the amount of bone density that the patient has. And so if a patient is dealing with higher grades of osteopenia or osteoporosis, we want to make sure the appropriate interventions are put in place to help increase that individual's bone density and lessen their risk for a fracture down the road. Another common medical test that you'll see done with individuals who have hip pain are going to be hip radiographs or x-rays. And hip radiographs are really good at picking up osteoarthritis, especially in the more advanced stages. And it's important that you know the classic findings of osteoarthritis that we see on radiographs, which are asymmetrical joint space narrowing, osteophyte formation, subchondral cysts, and subchondral sclerosis. These are important, as we'll talk about in a minute. The more of these that we see really helps us understand how advanced the pathology really is. Let's kind of go through these real quick. So with respect to the joint space, the image on your right, I drew a red arrow there, and I want you to appreciate the joint space between the femoral head and the acetabulum. And that joint space should be symmetric, meaning it should be equal all the way through. And if you look at that particular joint space at the top and at the bottom, we see decreases in the amount of joint space there. And if you look more medial to the femoral head, you see that joint space kind of open up a little bit. Asymmetrical joint space narrowing is a classic finding for osteoarthritis. If we're dealing with symmetric joint space narrowing, that's more consistent with inflammatory arthritis or something like rheumatoid arthritis. And so keep that in the back of your mind as you're studying these images. Osteophyte formation, we see these as extra bone spurs, if you will, sometimes we call them, and all they really are just a response to that wear and tear where bone begins to build up, and we sometimes see it at the bottom or the top of the joint there. And so if you look on the image on the right where it says bony spurs, that's an example of an osteophyte formation. Subchondral cysts are kind of interesting. On the left, you can see where I drew those tiny black arrows. You can see these little circles, these little dark circles, which are areas of decreased bone density, areas of lucency, where articular cartilage is kind of worn down, and we begin to see pockets of synovial fluid forming in there. So you'll see these dark circles. Those are subchondral cysts that form. And then subchondral sclerosis, if you look at the image on the left where those black arrows are, you can see how the bone around those black arrows is really, really white. What that means is that there's increased bone density in that area. Why? Because the joint space is now gone, the articular cartilage is now gone, so now we have bone on bone, and that bone on bone causes increased bone density over time, so we see that sclerosis there. So once again, the four findings: asymmetric joint space narrowing, osteophyte formation, subchondral cysts, and subchondral sclerosis, all key findings in diagnosing osteoarthritis. The Kellgren and Lawrence radiographic grading scale is typically used by radiologists and researchers to classify individuals according to the amount of radiographic change that they have. So for example, grade 1 would be very, very minimal or doubtful narrowing of the joint space, and there may be some subtle osteophyte formation. And then as we move up through grade 2, grade 3, and grade 4, we see more and more of these changes taking place with respect to more osteophyte formation, more and more decreased, more and more joint space narrowing, and we may see more sclerosis as well associated with this. And the bottom line with this scale is that the higher up in the grade that we are, the poorer the prognosis is going to be for conservative treatment. And typically we see individuals at grade 3s and 4s moving on to total hip arthroplasty. Folks at grade 1, grade 2, and even potentially grade 3 can respond quite well to our interventions. And so it's an important scale that you should know about. You'll see it used clinically as well as for research to classify patients in treatment outcome studies. As I mentioned in the last slide, the baseline grade that an individual has in their radiographic findings for the Kellgren-Lawrence radiographic grade is going to be important as a predictive factor for folks who are going to have to move on to operative management, THA, or total hip arthroplasty. And if we look at, once again, grade 2 or greater, it's a strong predictor that the hip OA is likely going to progress, especially in individuals a little bit younger. But as we look at grade 3 and grade 4 especially, the odds of an individual having a total hip arthroplasty go up significantly, especially with a grade 4. And so again, the Kellgren-Lawrence radiographic grades are important. They can help us establish prognosis, and they can also help us establish some understanding of who's going to do well with conservative therapy and those that might require operative management in the form of total hip arthroplasty. On the last slides, we described the radiographic criteria that are used to diagnose hip osteoarthritis. This slide looks at the clinical criteria used to diagnose osteoarthritis of the hip from the American College of Rheumatology. And if you look at this decision tree, we start with pain in the hip, and then at this particular point, we can go to the left or to the right, and really what we look at are range of motion findings. And so on the left, you see that hip internal rotation less than 15 degrees and hip flexion less than 115 degrees or a normal SED rate. The ESR there is an erythrocyte sedimentation rate less than 45, which means that generally there's no systemic inflammation occurring in the body. And so this is from a rheumatologic group, and so if that SED rate was elevated, there would likely be concern over some type of inflammatory arthropathy like rheumatoid. However, since osteoarthritis is not considered inflammatory, a lower SED rate fits that criteria. So on the left there again, if you're dealing with someone who has limited hip internal rotation less than 15 degrees and limited hip flexion of less than 115 degrees, you're pretty much good with knowing that this individual likely has hip OA. Also, if they have a SED rate that's normal, or in this case less than 45, that is a laboratory test that's used again to determine whether or not there's systemic inflammation in the body. Or you can go on the right side. If you don't have access to lab testing, we look at, once again, hip internal rotation less than 15 degrees. There's pain associated with that measure. We have morning stiffness less than an hour. Again, since osteoarthritis is non-inflammatory, we may get folks who wake up, they feel stiff in the morning, but it's gone by 30 or 45 minutes if it's OA. If it's rheumatoid, however, they'll be stiff well beyond that hour because that's an inflammatory disorder. And then age is in there as well. We spoke about that before. And so be familiar with these criteria. I think they're important because you could get radiographic findings, especially those grade 1 or grade 2 Kellgren and Lawrence scales. And we want to determine, is that clinically significant? And this particular criteria helps us do that. This slide shows what are called Altmans Criteria, which are essentially the same findings as the American College of Rheumatology. They're essentially from the same group. But if you look on the left again, the clinical criteria we're talking about are range of motion findings of hip internal rotation less than 15 degrees and hip flexion less than 115. No morning stiffness for more than an hour, and then pain with range of motion findings. It's important to mention the role of review of systems again with the subjective exam. And we introduced review of systems to you during the first week, I believe, of your first semester on campus. And so, as you recall, when we're dealing with patients with musculoskeletal disorders, it's important as part of our history to do a quick screen of their patient's general health. You can do this off of an intake, or you can just ask these questions. And so the questions we would ask are under the general health section at the upper left-hand corner of the screen here. And remember, we're going to ask these questions of all patients on day one. And if we get a positive response, it's important we follow up on it by determining the duration of that particular symptom, if there's a plausible explanation for why that symptom may be present, and if the physician's aware of it. If there's duration, a lack of an explanation, interference with function, and the physician's unaware, it's important we get folks referred back to the physician. Now, if somebody tells you that they have unexplained fatigue and there's some duration to it, that could be completely unrelated to their concern with respect to the hip. However, if we do have non-musculoskeletal concerns, there are some screens that we would use. When we start thinking about internal organs, we start thinking about the lower GI as well as the genital urinary system that could potentially refer into the hip or the buttock region. And those questions are on here as well in categories 4, 5, and 6. And so it's important to keep these in mind. These are questions that we're going to want to ask and help us move toward more confidence that the patient is either in the right place with you or they need to go off and see another provider. On the last slide, we described some of the questions you would use to potentially screen for a non-musculoskeletal disorder at the hip. This slide provides a list of some of the disorders that could potentially mimic a nonspecific mechanical primary hip disorder. And it's important to know that those questions on the last slide, as well as some of the findings from your history, will lead you into a physical exam that are hopefully going to help you determine is the patient in the right spot or not. And so once again, this is not an all-inclusive list, just provides some examples of some of the disorders that could potentially mimic a non-musculoskeletal disorder at the hip. In this presentation, we've discussed some of the key components of the subjective examination for patients with a primary hip disorder. What's next? Well, the next presentation, we're going to talk about the physical examination and how that's going to tie in with some of the information that we've gathered from our history and ultimately move us forward to designing an intervention for our patient. Thank you for your attention.